Hello, I'm Suresh Gunasekaran, CEO of University of Iowa Hospitals and Clinics and Associate Vice President for UI Healthcare. We are delighted to again be part of the Iowa Ideas Conference. Now in its fourth year, Iowa Ideas provides a unique opportunity to bring together a wide variety of different voices, perspectives, and thoughts to create a better future for us all. 2020 is a year that none of us could have predicted and has given us unprecedented healthcare challenges. In some ways, these challenges have made us better at delivering care, but it has also further highlighted the serious gaps some Iowans face in receiving adequate healthcare services. Let's start the discussions here and follow through to deliver better health for all. Thank you for being a part of this important discussion.
Good morning. My name is Kat Russell, and I'm the room host. Welcome to the Healthcare Access Disparities panel on the healthcare track. The healthcare track does have a sponsor that I'd like to acknowledge, and that's the University of Iowa Healthcare. You are welcome to submit comments or questions or thoughts in the Q&A chat box right to the right of your screen. And if you are using any social media during the conference, please remember the hashtag Iowa Ideas 2020. You can share your big takeaways or thoughts about the conference. And with that, I'm going to introduce our moderator, Michaela Ramm, and I am going to be quiet now.
Great. Thank you, Kat. Hi, my name is Michaela. I'm the healthcare reporter for the Gazette, and I'm also the moderator for this panel. As Kat said, this is the Healthcare Access Disparities, which is the Diversity, Equity, Inclusion panel of the healthcare track this year's conference. We have a great panel of experts today to talk about this, so I will kick it off to them to introduce themselves. Lina, will you get us started?
You bet. Thank you so much, Michaela and Kat, and everybody who's attending this session, Iowa Ideas today. It's a great opportunity for us to talk and share our insights with you. My name is Lina Reinders. I'm the Executive Director of Iowa Public Health Association. We are a nonprofit, nonpartisan organization dedicated to uniting and strengthening the voice for public health in Iowa.
Hi, my name is Vallejo. I'm part of LULAC, Cedar Rapids, Liga United Latino American Citizen, and I'm part of the group YPM.
And good morning, everyone. My name is Pete Damiano. I direct the University of Iowa Public Policy Center and the Health Policy Research Program within the center. And the topic of health disparities and access to care is something that I've been studying throughout my academic career. And then I'm also a professor in the University of Iowa College of Dentistry.
Great, thank you, everyone. Well, even before COVID-19 pandemic highlighted the conversation around healthcare access and healthcare disparities, certain populations have always struggled with this particular issue when it comes to accessing medical care, not just to overcome the determinants, but also, not only to access that healthcare, but when it comes to overcoming those determinants of their health. But before we get into that, I think it'd be worth covering what it is exactly what we're talking about when we talk about things like social determinants of health and what it means to have disparities to access. So Pete, I was hoping you could kick us off and talk to us about what it means when we talk about social determinants of health and when it comes to access disparities.
Sure, thank you, Michaela. There's a few things that I always like to kind of lead into this discussion because it is so broad and there's so many different ways that you can address it. All of them are worthwhile. When I think about health disparities, I go back to the CDC definition that really is preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health care that are experienced by socially disadvantaged populations. And that's obviously very, very broad. But I think it's a good place to start. And then we can sort of tease out some different components of that. We often think of health disparities by population type. And so the populations we often think about are different groups by race, ethnicity, or gender, education, income, disability, geographic location, sexual orientation, to gender identity. A lot of those kinds of are sort of the groups that we often think about when we're thinking about disparities. But they also are involved with, getting closer to that idea of the determinants of health and things like poverty, environmental threats, inadequate access to healthcare. That's why one of the reasons this title is sort of bringing access to healthcare and disparities together. Individual behavioral factors, things like that, which really then leads to what I think is one of the major divergences, if you will, or major ways that you could think about that, and that is disparities in terms of our health status or disparities in terms of our access to health care. And they're very different if you really start thinking about what the impacts are on the relationship, where the health status is that thing that really comes from the idea of what we often call social determinants of health. I often drop the social and just call it determinants of health, because it sort of makes it sound like it's soft and mushy and really not that important. But these are the things that really determine whether we are healthy or not. And these are early childhood development, education, employment and working conditions, and everything that comes from having a job in addition to the income and the self-esteem, food security, health services. Housing is one of those that's probably one of the most important. There are a lot of people who think of the idea of housing first, which I think makes a lot of sense. If you don't have safe, secure housing and reliable housing, none of the rest of these things can follow. If whether it's, literally being on the street or couch surfing or just, right now with COVID, we know there's a lot of people that are losing their lease, or they're not supposed to be, but there are a lot of challenges. And then how can you really think about all the other things? Income distribution, social exclusion, and, social right now has also been sort of back right in our face with COVID, and how important that social support is a part of both our mental emotional health as well as our physical health, the whole social safety net and job security. And so when we think about those determinants of health in the United States, and where do we put, healthcare use is one of those, but if we really think about what is it that makes us healthy among that combination, it's really only the healthcare delivery system is only about 10% roughly. You could argue with what these proportions are. When we think about what really determines whether we're healthy or not, about half of it is lifestyle factors, which are really then related to those determinants of health. And you can think about what are the kinds of, lifestyle factors that might factor in, whether it's substance use or using a seatbelt or, nutrition, physical activity, all of the things we think of. Environmental factors are about 20% roughly. Our genetic component, we all know people that live to be 95 and smoke like a chimney, and other people died at 24. So, you got to combine all these things together. That's not necessarily something we could have a policy discussion about yet. When we have individualized healthcare and you have, Star Trek wand that can fix people by their genetics, maybe we can get to that. But then the healthcare delivery system's only about 10% of that. But if you look at where we put our resources in the United States, about 90% of all of our resources go into what affects 10% of our health, which is that healthcare delivery system. When you're looking at Lina and public health perspective on this, it's really public health and population-based healthcare and health behavioral kinds of things that really are going to affect most of the other things, or a public health perspective on the environment that are really going to affect that part of our health. And we only put 10% of our dollars into that, and it's not something we think of as always being a part of health, but those really do drive a lot of both the health disparities in our health status as well as access to care. So with that, I will turn it over to Lina, or I'll turn it back to Michaela. She can take it from there.
No, you did what I was going to do, Lina. I was going to ask you to kind of share your thoughts on that. I guess, what do you think on this realm from a public health perspective?
No, I appreciate that. And thanks, Pete, for setting us up. And you're right. The majority of our resources when we think about health are dedicated to health care. but our health is created in our communities, and not just by the individual choices we make in our communities, but those choices that we are essentially set up to be able to make. We like to say that the healthy choice is the easy choice. We need to make sure that the healthy choice is the easy choice, or in many cases the non-choice. I remember when I was teaching at Simpson College several years ago, I asked my students to kind of divvy up the side of the room whether or not they had ever heard the phrase, walked into a restaurant and heard the phrase smoking or not. And I figured it'd be about 50-50. We kind of said, some attitudes about should smoking be allowed in restaurants. And much to my surprise and my delight, all of my students went right to the side of the room where they said, no, smoking should not be allowed in restaurants. And I don't think any of them had ever heard the phrase smoking or not. And I started my career in the early 2000s working in tobacco control policy, and that would not have been an issue. That would not have been the same results. There were huge fights and disagreements over smoking in restaurants. And, we see a generation later that has become the norm. And so the healthy choice is the easy choice, and really the non-choice, because that is what we have done in terms of policy decisions and systems change. So just a little story to set us up here, but really the social determinants of health that Pete were just describing are neither natural nor inconsequential. More often, Pete just said that social determinants of health, determinants of health, but a word that's often missing is political determinants of health. And when I say this, I don't mean partisan politics, rather that the results of policies have become entrenched in our systems, and at best, they've had unintended consequences. At worst, some of these policy decisions were intentional to segregate groups of people, like what we've seen with redlining. And we are still, and despite the fact that redlining, which is, determined who could buy houses where, despite the fact that policy has since been stopped, we're still seeing the effects of that in people's health. So across the board, we do see dramatic disparities in both healthcare access and outcomes. We see it in physical health, we see it in mental health. The number of Black individuals who report poor health in the last 30 days was 22% higher than white individuals in our recent study. This is per IDPH data. Mental health, there was more than a 2 times differential between Blacks and whites. Hispanic individuals, which I need to point out is an ethnicity, not a race, and therein lies some inherent problems with our data collection, actually have the lowest reports of poor health, which is great to see. When we drill down the physical health, we look at diabetes. There's a 20% increase in diabetes for Blacks over white individuals, and infant mortality is often a measure that we use as a proxy to the health of a community and our investment in health and such. So when we look at infant mortality, we do see, again, between Black infants and white infants, a 2 times the rate. So we're losing Black babies at twice that of white babies. And that's really across the board. And the same is true for maternal mortality, which is, people are shocked to hear, is on the rise in many places, including Iowa. And when we look at overall life expectancy and the differences that we see there, life expectancy in Iowa is about 79, pushing 80 years on average for everyone. But again, when we talk about health equity, we have to drill that down, and we have to disaggregate that data to see what we're really looking at. And so when we do that, we see a range of life expectancy from 66 years, an average of 66 years, to that of nearly 90 years. And what we see when we look at the patterns of those data is that it can be linked to your census tract. I mean, yesterday was the deadline for the census, right? And so we're thinking of census and what that means. And so what that tells us in public health is that there is something going on at the community level that is impacting people's health to the degree that it is affecting their life expectancy. And so we see these disparities across the state and within counties, within Polk County, within Black Hawk County, Dubuque. You can see per census tract, a very different level of health based upon where you live. And so when it comes to inequities, if we are not intentional about addressing them, we may unintentionally widen them. So let me get back a little bit to public health and a kind of a history lesson in public health. One of the first allegories that is shared with public health students, like first day of class, first class of the year, is that we call it the public health parable. And it's that of two friends walking along a river. And maybe some of you have heard this, but I'm going to repeat it just in case some haven't. And it is worth repeating. So suddenly, you're walking along the river, a couple friends, and suddenly a person comes down the river, is flailing about, calling out for help. So what do? Of course, you help them. You pull the person out of the river, you render care, and you think, phew, they're glad that's over. But then here comes another person. You pull that person out. Here comes another person. You pull that person out. And you're seeing this trend of people coming down the river needing help. Suddenly, one of the friends gets up, leaves, starts walking upstream. Leaves the friend and says, what are you doing? Where are you going? These people need help. And the friend that's walking upstream says, I'm going to go find out why these people are falling in the river. And that's the problem that needs to be fixed. So again, that's kind of how we characterize public health and health care. Both are necessary. We need health care. We need the downstream care to help people who are injured and sick. But we also need that upstream approach to stop people from falling in the river, right? So if this system works, if this upstream, downstream system works, then why are there disparities? Well, when we look at that, when we examine, perhaps the friend who went to find out why people were falling in the river didn't examine who was falling in the river and why they were falling in the river and who wasn't falling in the river. And perhaps the friend who was rendering care wasn't noticing that it was the same type of people who they kept pulling out. Perhaps this was ingraining that this group of people was somehow at fault or predisposed to their fate. And so it begins to affect how we see the problem and how we then look for solutions. And so while we've espoused the importance of upstream thinking, by focusing on lowering absolute rates of diseases, we've lost sight of the widening disparities in many cases. So I'll say it again, if we are not intentional about addressing disparities, we risk unintentionally widening them.
Yeah.
So public, do I have time? Okay.
Yeah,
So public health as a field is in a bit of a transition of what we are calling 3.0. And so when we, again, a little bit of a history lesson, 1.0, early 20th century, it was really about sanitation, controlling very basic diseases. 2.0 is when we saw the rise of local public health departments and really focusing on disease models, disease prevention, community focus. But a lot of that work was dependent on funding. Pete talked about how we fund our public health and healthcare system. And so necessarily we work where the money is, unfortunately. Like I said, I started my career in tobacco policy control. That was because in the early 2000s, there was a lot of money, public and private sector being invested in tobacco control. Unfortunately, that method of siloed disease prevention and health programs, while it may have brought down overall rates, again, we did not see the closing of the disparity gaps that we had wanted to see. So public health 3.0 is what we're doing now. It's kind of where the field is moving to working across sectors, working, as Pete said, with education, with housing, with transportation, with jobs and employment to disrupt the systems that maintain and reinforce inequity. So we're really talking about systems right now. So we know that if we want to improve the health of communities, we have to build trust and relationships and work on those foundations of health, livable wages, education, access to quality, affordable care, and so on. And so while these are not areas, while these areas are not the traditional domains of public health, they all contribute to public health. And so if we don't build these partnerships with subject matter experts and community experts, community leaders in these public health adjacent areas, we won't ever truly prevent people from falling in the river. And so we do this, the question is, how do we do this? It's a big, big question, right? We start by naming structural and systemic racism as the public health crisis that it is. And we acknowledge that the calls for social justice are an act of public health, and by equally acknowledging that privilege exists within the field of public health. We are largely a white middle-class profession, and that is true for the same is true for healthcare. And so given this, we can't overlook the historical mistrust, historical and historically justified mistrust of healthcare and medical research that goes into people's, that impacts healthcare access, which is what the panel is about today. And so when we unpack access, we see that access is not simply a door to the clinic or a door to the hospital. When we unpack that, really what we're talking about is care that is available, accessible, affordable, appropriate, culturally relevant and sensitive, that is timely and is effective. And so we have to measure all that when we look at healthcare statistics. One of the statistics that's often used when we talk about inequities is breast cancer rates. And what we know about breast cancer rates is that more white women are diagnosed with breast cancer every year than Black women or than Hispanic women. Again, Hispanic being an ethnicity and inherent data problems there. But what we see when we look at survivability is that it's flipped. And so even though more white women are being diagnosed with breast cancer, more Black women are dying from it. And so we have to ask why. Why is that? And so one of the most important questions really in public health and in healthcare is, but why? So Black women are dying more often from breast cancer than white women, but why? Black women tend to be diagnosed at later stages of the cancer, but why? Black women have lower rates of mammography, but why? Mammography isn't readily available at community clinics, but why? So you see where we're going with this. The more we ask, but why, the closer we get to the systemic barriers and access to care. But it can't stop there, because the next question we have to ask is, are we prepared to break down those barriers and create a healthcare system that is equitable and truly accessible for all, using those factors that I mentioned before? And so we will know that we've achieved health equity when race is no longer a predictor of one's health as it is today.
Absolutely. Well, great. Well,
thank you. I'll ready to turn.
Great. Thank you, Lina. Thank you so much for that great overview. I think this is a great way to introduce us to the larger issue kind of broadly, but I want to take a moment, Monica, and talk to you based on your experience in the population you work with. You know, when we talk about healthcare disparities and access disparities, you really see this firsthand in the population you work with. So hoping you could take a moment and talk about what it means for these populations, you know, as you know, to kind of borrow from Lina, the people who are falling in the river.
Yeah, thank you. Yes, with my experience working with Hispanic families in Cedar Rapids for many years, I cannot agree more what Lina say, how they want to see what they fall in the river. Everybody, they don't fall the same way. Some people maybe because they don't know how to swim. Some people maybe they don't know there was a line over there they can need to avoid. So this is an example that not everybody have the same problems. A lot of those Latino families, Latin families, they are maybe lack the information, maybe lack a very good health insurance, or maybe because they cannot afford have health insurance in here. So what they have to do is to go to different free clinics, and they trying to, the people they don't have health insurance, it's very hard. One, the language period. This is so difficult for a lot of those families. They don't have a very good health insurance, or they don't have very treatment in Cedar Rapids. And the problem is the language, like I say, different programs offer translate persons, but other programs they not. So they have to go with a family member, even with the kids, to do the translation. And I think something that we need to do and be conscious, health is very high risk. I cannot trust my health with my son or with my younger grandkid. I have to trust the very delicate information to a person who knows very good the language and who knows professional the language. So we cannot trust anybody to come in to translate. I think the help in Cedar Rapids, I can say for Cedar Rapids, different organizations, they do a wonderful job. Even to do by this way, from Zoom, from Skype, from whatever video, but you can see the person and translate. But the person's different organization or different office, doctor office, let people that are not professional to translate. So there's a lot of families, they have to be called to the translate persons to translate for them. And it's very hard and difficult for especially, I can say the population we serve, the mothers, if the kid is sick, they have to call the translate person first. What happened, the translation person is busy, they cannot answer the phone, and the baby is sick, what do they need to do? Take to the ER, because they know in the hospital somebody speaks Spanish. Or take the walk-in clinic, somebody can find somebody to translate. So my point is, we have to be more professional as every single doctor office or to find a person to translate in the office. And the problem with the lack of information with the families and let it be difficult for them to go to any clinic or any doctor. More the family, the Latino families, they don't have a family doctor. So when the COVID came to this year, what happened is everybody was scared. I think everybody was scared because we don't know what is going on with this. So if we are scared, we understand English. Can you imagine people, they don't speak English, how fair they can be? So they are so afraid, they don't even call any places, they don't call the doctor, they don't get tests because they call their families in their countries to ask what is the best medicine, what is the best solution. So they treat by, they think the people say this different kind, the treatment in other countries, the housing or medical, I don't think so, but people they call and say, oh, take Tylenol, oh, take aspirin, oh, drink this water. So because they don't trust to us, because they don't have the access to a doctor, even that they call me and say, what do you want me to do? I give the number, I make an appointment, but I have to be referred for family doctor. And a lot of those families, they don't have family doctor. They can afford to have insurance. Some, for legal status, they cannot have insurance. So for those families is the one I talk about them. Because the families that have insurance, families that speak perfectly English, then they can afford, if they have a insurance, they can go wherever they decide. But the families, they don't speak English, is very hard. For those families have a lot of people with COVID, there was no report, and the very sad situation is if the mother or the father who has to provide the well for the family get sick and don't go to work, they don't have another income. How they pay the rent? How they pay the bills? They can apply for any help. For legal status, they cannot apply for different help in the city. Is another, the Latino families, they are very hardworking people. They are in front of the line in the work. They have to work because the other way who pay the bills. We are not the kind of people they like other people pay our bills. We work very hard for those, whatever we need to do. So this is the situation I'm very, very sad for those families because this is I lack the information. The big gap is the language barrier. Is then the community, they are not, it's not the same. The immigrants, we are different kind of immigrants. We are different kind of immigrants. We are not the same. And the Latinx, for the Latino family, they treat us like the same immigrants from the other countries. We are not the same. Like Lina say, have to go and see who's falling in the river. And the river, we fall different kind of people for different many ways. We have to see how different we are from the other immigrants. Not every immigrants, we are the same. But the immigrants from Ecuador, other people from Mexico, a lot of people from Guatemala, people from Peru. So we are not the same. We have not the same situation. Like you say, the breast cancer, yeah, it's a lot of high level, the diabetic and Latino. I say too many times, we are talking about with families, why and the family have to be so high level, the diabetes, because people, they don't do too much exercise, they doctors say, maybe because the diet they have is not very healthy. Yeah, I understand that. Maybe because they don't have too many ways to learn. Yeah, I understand. But who teach those families what is the best? Where they can find the food they need to eat to prevent not be diabetic, the kids not be diabetic. When they go to buy or they donate food or the different places they donate food, they give a cereal and pasta and cereal. So if the people are hungry, they're going to eat cereal. So not in every place they give you vegetables. So this is the kind of education we need, more education for everybody, not only for Latinos, but for the people who serve to Latinos. Have to be more sensitive to the culture. What happens when you go to different countries? How are you feeling? If you know the language, where do you go? A lot of people, when they travel to different countries, the first thing to do, okay, what is supposed to say? I go to the hospital, or there's something happened to me, take the dictionary or now the telephones. And a lot of people say, what if they don't learn English here? Yeah, take the time. It's nothing they learn the 1 week, 2 weeks, and 1 year. Take time. If you don't have, the only income that you have is your husband, how they can learn English? Because there's 2 places to learn English. Kirkwood and Catherine McConnell Center. So if the schedule, they don't help you, how they can learn English? So, and learn English is not like learn mathematics, no. Take the time. And maybe they say, why they don't come and learning English? Yeah, who take care of the kids? Who take to the classes? They don't drive. Take the bus. Okay, take the bus. How often the bus is in Cedar Rapids? Take forever, especially in winter time with the kids. Who can go to the classes with kids? So it's different things in the community that we need to try to fix. They're not trying to be understanding, trying to help to us. The family, a lot of times feeling so lonely, especially they don't have any different programs that accommodate to the Latino families. So diversity is not only Latinos, diversity is Asian, African, different people that come from different countries. So before we fall in the river, we have to know who fell in the river and what the situation or why they fell in the river. What happened when they know how to swim, they fell. We had to know a little bit more about the Latino community. What is the situation? People, they say, oh, they don't have legal status, it's not our fault. You don't know how people, they live in their countries. Maybe here they have a deal meal, maybe in their countries they not. They have the kids in the United States, the kids are American citizens, they have the same right that you son and my son, they have in this country. Okay, the parents maybe they not have a legal status, but the kids are, and they have the right to live free in this country and have the same access that every child has in this country. This is my opinion.
Yeah, absolutely. Well, I really greatly appreciate your perspective on this, Monica, and I appreciate all our panelists introducing this very complex and broad topic. I think to all your points that you're making is that this isn't just a one solution type issue. There are a lot of facets involved with this. You know, taking all that in mind, I'd like to kind of switch gears a bit and talk about how the COVID-19 pandemic has really changed this conversation. And to start off with, I'd like to kind of get directly to the healthcare systems and sort of maybe how they view this issue. You know, I had a panel yesterday with with Unity Point Health CEO who she raised the point that hospital systems are aware of the fact that COVID-19 has really largely impacted certain ethnicities and populations of color way more than it has for the white population. And, you know, they're more likely to be sick, more likely to die as a result. Healthcare providers are thinking about this, but I'm curious, panelists, if you see that broadly, are these conversations happening nationally? And is it enough to really kind of change the conversation once these populations do arrive at the hospital? They're perhaps more aware of this, or maybe there's efforts being made to address it earlier. I leave that question open to anybody.
Michaela, I'd like to loop that back through something both Lina brought up and then something that Monica brought up. I'm not sure how much of the disparity that we're seeing is, again, because of the delivery system. I think a lot of the disparities that we're seeing go back to what Lina was talking about, in the lack of any kind of a public health system and or any kind of a healthcare delivery system. I mean, even President Bush's Secretary of Health and Human Services used to say, we don't have a healthcare delivery system in the United States. We've got a group of healthcare sectors. But that's once you land on the doorstep and the access to care issue. But it seems to me that a lot of the health status differences and mortality rate differences are because of public health related things and the determinants of health that have happened prior to those people getting to the healthcare system. So they're coming in a lower health status. They're going to be, you know, higher rates of diabetes, all the other things that we're talking about, and that's going to set them up because of a lack of system. Not that there aren't going to be differences in the level of care they might be able to receive and their knowledge of when to go in, but I think so much of it, because we don't have a really good coordinated public health system, an educational system that goes along with that in terms of how to prevent, you know, the spread of COVID and the mixed messaging that we've obviously been hearing from even within our state public health system, that, you know, especially if you're talking about Hispanic Latino population, you know, who knows what the message is getting there and how it's getting there. Monica could speak to that much better. The other part of that I think is also real interesting related to COVID is this whole issue about essential workers. And Monica was sort of talking about that. And this is the first time that we're beginning to have a little bit of a conversation. And you think, who are the essential workers? The essential workers aren't us, you know, upper middle class white folks for the most part. Many of us, if we're not there, COVID, the world could keep going. But the folks that we are relying on do tend to be lower income, a lot of Black and brown population, folks who are working in jobs that other folks don't want, and those are truly essential. Are we really going to look at that and think about what does that mean for the future for all of our health? Are we going to be thinking about whether it's immunizations, not, you know, access to them and the messaging that go along that people would want to do it, as Lina was sort of talking about as well, with some of the uncomfortableness, let's just say, between many populations of color with the system, and whether it's, but not only those kinds of things, but also, are we going to pay a living wage? Are we going to provide health insurance coverage? Are we, all of the other things that really help protect all of us? Sick leave. Do we really want to continue to have people have to go into work when they're sick because they have no choice? What does that mean for the health for all of us? So I think there's threads of the things we've been talking about that are directly relevant to COVID. And I hope we continue those difficult conversations as we move forward on what to do about that. But it's going to be real easy to just fall back on those things, because those are.
Yeah, absolutely. Around these conversations about addressing the disparities even before these populations land at the doorstep of hospitals, have you as panelists seen any, movement toward a solution to addressing these particular determinants, before they get COVID or before they get any type of illness? What kind of successes, if you have seen any, have you seen in this particular realm?
Sure. We're part of a group that is looking at the different roles people are playing, different organizations are playing, to look at how they're addressing equity within their own sectors. Like I said before, that we are really working, public health now is really tasked to work across sectors to impact the systems. And so we have been, Iowa Public Health Association has been convening groups of people for the last several months to look at those and to map some of those exercises, some of those activities that people are doing to tackle equity in their subject matter areas, with the idea that if we can convene people that don't typically or naturally work together, but we can come together, map what everybody is doing, and we can look to see where those synergies are, and more importantly, where those gaps are, so that we can say, this area isn't being tackled, so who's going to do that? And what our hope is that we create kind of an overarching equity agenda that can be used when we advocate at the legislature, when we advocate at our local levels, either local boards of health, county supervisors, to where we invest our resources, where we invest our time, the relationships that we build. If we can work towards equity being a goal, then slowly by slowly we can get there.
Absolutely. Great. That's wonderful to hear that there are conversations happening in this realm. In an earlier conversation with the panelists, you all brought up telemedicine as a potential solution to this. Easy and earlier access to these populations may sort of combat that historic distrust that we talked about when it comes to these healthcare systems among these populations. But I wonder if we think that this is if this is a good long-term solution, in the terms that not everyone has access to technology or even understands it, and I'm thinking about Monica's point earlier about the language barrier. I wonder how big of a role that could play. So I wonder, do we think telemedicine could be a great solution for this particular conversation, or is it just sort of a piece in the pie?
I think, in my opinion, this is going to be the piece in the pie, because it's something to start at least. In the future, I think it's something better options for right now, because I think because there's COVID, because the derecho, the families have to be a little bit more into technology, not only for the medical issue, but the school. So they know already how to use Zoom. They know how to use web cameras. They know how to use WhatsApp cameras. So technology is something that we need to start use to help our communities, especially the ones they lack for the language, not only for Latinos, but for other language too. If we cannot have somebody to translate in the place, they offer the service, at least we can have somebody to talk on the phone. Don't trust the person who translate for you if they don't know, excuse me, if they not a person, a specific expert in this kind. So I need somebody to translate to me. I want somebody they know already what they do, a professional translator. We don't have too many, we know that, but we can have somebody by technology. It's more easy and more comfortable, and I think because I can see somebody, when I talk with families and I say, you remember you have to tell your doctor what happened with your son, what they start the fever. And when I told, what is the fever? Say, oh, I forgot about that. But the person that I told, the translate person, I told her and she forgot. You told about the front head that you son, there's something wrong. Oh, I forgot. Oh, she don't say anything to me. So this is what I say. This is not 100% trust the person who translate to the families or to the person. Maybe use the technology that can be with a professional people. Maybe they can be more trust and the people that can be more easy to explain what is going on. Because the person who translate, they translate very easy because have to go to the other person. So this is something we need to think about it, how the service we're going to do. And for families, the COVID-19 was so difficult, and there's a lot of families, they get the COVID, but they was don't test because they are so afraid to go to the doctor because it's so expensive and stay in the home. And sometimes in one apartment and one house live 2 or 3 families and they share the one bedrooms. So it's so hard. It's so hard for Latino families when they don't have a very good communication with the community, and the only hope is, in the time I was very sad because something happened that impacted my family. So in the same time, a lot of families was impacted with the same problem. So I have to call every day, how you doing? How is your husband? How is your daughter? How are you feeling? Take Tylenol, drink water, drink a lot of liquids. So into the pain that I have for my family too, I had to be strong for other families. They have the same situation. I have insurance, my family have insurance, and I can call the doctor. I can call my doctor. I can call my daughter, can call her doctor and make the appointment and send to do the COVID test. For those families, they don't have family doctor. That was very difficult to have the COVID test. They have to give the telephone number. I called for them, and it was so hard. It was so hard. So the family, they decide to be sick in the house. So there's a lot of families that was not counting this number, and I said it was so bad. Plus the places where they were, the first month, that was so difficult and different information. They don't follow the rules. They don't care about the employees. If they're sick, they have to come to work. With fever, they have to come to work. So I think after the second month, I think that was better. And I know it's very hard to use masks, but I think we have to push a little bit more. And I do everything I can with the Latino community to use masks. And this is what have to be more strong and push a little bit more. I know it's something not everybody like to do, but it's the more safe to do, especially with the Latino community. They're more sensitive, and we don't have too many places to go to doctors, or not only for the Latinos, for everybody, they don't know about this thing. So it's difficult. Communication is difficult for Latinos if they don't know the language. With people, they know the language and they know how to go to the mobilize inside the community. It's so easy. But other people who are not, this is what I'm talking about.
Michaela, if I can add a little bit to the telemedicine discussion as well, I think everything that Monica said is so valid, and in language especially, but also representation. And what COVID has done for us is, yes, it's highlighted all the disparities that that those people who are not already, invested in public health, healthcare, immigrant communities, maybe they hadn't seen or as readily before. So it's highlighted that, but it's also really given us an opportunity to advance how we care for people, the decisions that we can make. And so when we look at recovering from COVID as a society, as an economy, we really need to make those hard choices, the right choices, to invest in the things that will bring us to a higher level of equity as we rebuild. And one of those things is telemedicine. So telemedicine really has advanced faster. I mean, it's been on the horizon for a long time, and people have been advocating for the use of telemedicine for a long time. And COVID kind of forced that issue for us. And so the question is, do we keep it, or do we go back and having to start fighting for it again? And is it a reimbursable service? And the benefit, one of the benefits of telemedicine is not just language, but like I said, representation. Take, for example, mental health care in Iowa. We know that we have a mental health crisis, but particularly so for Latinas, for Black Iowans, for people who don't see themselves represented in the care provider that they seek. And so if you don't, so number one, we don't have enough providers, mental health providers in Iowa. Number two, we don't have enough providers of color in Iowa. And so if telemedicine gives you the opportunity to see care providers that you see yourself reflected in, then that's another win. That's another reason that telemedicine can help bridge some of these gaps. But of course, that goes hand in hand with broadband access. I mean, broadband and mobile technology is really, it started out as a luxury item, and now it's a necessity item. So we need this as a utility to access the services that we need. And then to Monica's point before too, so that what telemedicine can do for the cases where it's appropriate, if you don't have transportation, the bus isn't coming, you don't have a car, you don't have childcare to watch your kids, well, telemedicine helps solve those problems. You can visit with your doctor without having to worry about bundling up your kids for the winter on the bus to get there. And so all these barriers of healthcare access, a lot of them can be solved with telemedicine, and it can help us get to that next level of equity.
And I think one of the things that I hope we can get beyond, we have to talk about specific populations that are affected more than others, and that's just a part of this. But there are aspects of this that affect everyone. And so we don't have enough mental health providers in the state for everyone. And whether that's urban or rural, that's adults or kids, teenagers. And so often we're almost pitting groups against each other when we have these conversations, or it can seem that way, instead of, really, how do we get to that serious conversation about we are all in this together? And that issue that Lina was just kind of getting at, well, what could be a post-COVID economy? Well, there aren't great levers to make that happen either. We're not great at, okay, thou must, but if we really do want to believe that we're all in this together, we may have to do a few more of those things and do some things that are going to say everyone does have to have, whether it's health insurance coverage, truly, we made an attempt to gain 22 million people at the ACA. We know that in a week after the election, there's going to be a Supreme Court decision that might impact that, and we could slide back. So then that would mean either way, I think likely there's going to be some efforts in the Congress to make that, so to solidify that. And are we really willing to do those things that will help everyone? And if you look at like insurance coverage post ACA, it really decreased the disparities, racial, ethnic disparities and others, but it also helped everyone. And when an uninsured person gets insurance, it helps the person with insurance because we have less uncompensated care, which is lower cost for them. And we don't talk about this nearly enough, or I think as effectively. It is hard, but I really hope with this post-COVID economy and the opportunities, whether it's telehealth or other things, we really can think about it a little bit more, that we are all in this together. And you being healthy helps me. The last thing I'll say in terms of COVID, it's the whole mask thing. So it's like, you know, I heard Chris Christie talking today about, gee, I should have worn a mask. But that's, again, the wrong way to think of it, because he's thinking I would have protected myself better. And we know that masks, when you wear it, you're protecting other people more than you're protecting yourself from COVID, unless you've got a fit tested N95 mask, you know, and a shield and a second mask over it and all those things like we have to wear in the clinic. Otherwise, when you wear a mask, you're helping the community and you're helping other people. And so it'd be great if we could really start thinking about all of these things much more collectively, and we would all be in a better place, both from a health status perspective and an access to care perspective.
Yeah, absolutely.
One of my favorite quotes is, we all do better when we all do better.
Yeah, absolutely. Yeah, that is an excellent point. And, you know, kind of going off of that, in terms of thinking, whenever we reach a post-COVID world, we're talking a lot about economic recovery. And I think this is to a point Lina brought up earlier about how we apply a health equity lens to this economic recovery. You know, you kind of talked about it briefly, but I wonder if there are other ways that we could think about it. What other things could we use sort of that economic standpoint to apply to this conversation about healthcare access and disparities?
Well, I think one of the important things that we have to think about is, who are we having those conversations with? And the way back in the beginning, like I think it was in April, we published an op-ed in the Des Moines Register that said, as we look towards recovery, I mean, back in April, we were looking at, you know, how do we plan for recovery? Those conversations about healthcare access, about insurance coverage, about employment, essential workers, you know, paid sick leave and stuff, they need to happen not just with the CEOs and the CFOs of organizations, but they need to happen with the people who are working the line, driving the bus, you know, those essential workers. And to Monica's point, have the translators that there are ideally the people who are native speakers to be involved in those conversations. The conversations can't only happen in the C-suite. They have to happen across the gamut.
Yeah, I agree with you, Lina. We have to, not only the people in the CEO, they're going to talk about something that benefit them, but they're not going to talk with people that was affect for the virus or affect for the situation with medicine. So I agree with you. They have to talk with people, with the people work in factories, people work in restaurants, people they work in front lines. So they have to be a conversation with community, not only in the office, not only with the big people and CEOs. I think they have to talk with the people in the community, who's the affect with the situation.
Absolutely. Absolutely. Pete, do you have any thoughts to add to that at all, or any other final thoughts?
Well, I mean, I'll go back to sort of where we just were, because I think it's still relevant, but are we going to have any kind of mandatory sick leave? Are we really going to have consistent policies on things that we know are going to help prevent the spread? Are we really going to be thinking about the health to open the economy instead of the open the economy and thinking that somehow that's going to improve our health? But ultimately, are we also going to fund a public health system? And are we going to give the counties and the regions the support that they need to be able to have the expertise and work with the communities who may not have the same kind of access to information that we've been talking about? This is really hard work. Behavior change, we don't know how to do behavior change well. You know, education is not sufficient. And we don't even know how to do the education part. I mean, it's necessary. We have to have that first. But if we really want to change people's behavior, that takes a lot of effort. And a lot of us don't even want people, you know, affecting our behavior anyways. So you're dealing with sort of a very challenging situation. But, you know, will we truly get to essential workers are essential? And so we want to make sure that they are healthy and they are there and available for all of us. And then that helps, you know, us, and what is our role in that? And I certainly hope that we can, whether it's at the state government level or the state legislative level or the federal legislative level, so that we can truly get to the evidence-based discussions that we need to have.
Absolutely. Well, great. Well, unfortunately, I hate to cut this off, but it looks like we are out of time. Just kind of some last housekeeping things before we send you on your way. You know, if anyone has any questions for our panelists or would like to continue the conversation, please, I encourage you to use Whova, whether through the app or through the website, to message our panelists directly or use the chat function to continue this conversation amongst yourselves. Next up is our closing keynote for the conference with David Kennedy, who is with the National Network of Safe Communities, which should be a great conversation from him. And after that will be our virtual happy hour. Hopefully you guys can take a moment to be a part of that as well. But that's it for the healthcare track this year with the conference. I wanted to thank our panelists again for participating and having a great conversation. Also thank all of you for attending. So thank you all so much. Hope you all have a good rest of your day.
Thank you.
Thank you for the invitation. Great to be with all the panelists, and thanks to everybody who
Thank you, everybody. Gracias. Muchas gracias.